My great pleasure to introduce one of our newest faculty members in the Department of Otolaryngology, Head and Neck Surgery in our Head and Neck Division, Dr. Andre Finegersh. Dr. Finegersh completed his Head and Neck Fellowship with us at Stanford just about a year ago, and then we were fortunate enough to keep him on our faculty. So we're delighted to have him here with us today. His research lab focuses on the epigenetics of head and neck cancer, but what he's going to talk about today is minimally invasive surgery for head and neck cancer. So thank you so much for joining our team and for being with us here today.
Yeah, thanks, Heather. And it's really good to see so many patients, and a lot of patients I've been able to take care of over the last year doing well and enjoying the meeting. Yeah, I wanted to just maybe go over some of the newest trends in head and neck surgery, let everyone know what we're doing as surgeons to try to make surgery easier for patients, and as far as minimally invasive procedures. And I think, just taking a step back, I think the word minimally invasive isn't really well defined. As surgeons, we don't have a definition of minimally invasive. In head and neck surgery, it's probably synonymous with scarless surgery, being able to perform a procedure without making any incisions on the patient. And the way we're able to do this in head and neck surgery is actually by, placing instruments through the mouth, through the nose, taking advantage of the body's natural openings in order to do surgery without scars. Additionally, in head and neck surgery, it's really rich in new technology. So one of the biggest innovations in the last 10 to 20 years is the advent of surgical robotics. And so we're taking advantage of these really sophisticated machines now in order to perform minimally invasive procedures. So as you can see, this is a Da Vinci surgical robot, which is made by Intuitive down in Sunnyvale, so a Silicon Valley company. And it's the most widely used surgical robot in the world currently. And, we have a few of them at the Stanford Hospital that we use. For head and neck surgery, we're actually a very small part of the market share for surgical robotics. So I think for Da Vinci, we're only about 5% of their total market share. So the majority of surgeons that use the robot are urologists, general surgeons, and also gynecologists. So I think it's a growing field, but we're still, as far as surgical robotics, head and neck is still just like a small piece of the pie. The important thing when we think about improving procedures is making sure that they work, not just in making the procedure scarless or improving, swallowing or voice outcomes, but also making sure that they work for curing cancer. That's the first and foremost reason that we do the surgery. And so all these technologies, new procedures, they're evaluated with clinical trials. And if not clinical trials, then at least, hundreds and hundreds of patients that have undergone the procedure, where we can look back in time and make sure that those patients that had a robotic surgery, a minimally invasive surgery, actually had a good cure and not just a good cosmetic outcome. And then, as always, patient selection is the key. There's some patients that maybe you could do the minimally invasive procedure, but it's not the right thing for them. And so the surgeon is the one that has the training and all the available tools, but has to make a decision for what's the right procedure to perform. And then I like this cartoon. This is actually, I think, the opposite for us as head and neck surgeons. This is a surgeon telling a patient, I can offer you a much less invasive treatment, but it wouldn't be nearly as interesting to tweet about. And so for us, actually, because these robots are so cool, we actually do tweet about them. Here's Dr. Holsinger's Twitter. I found he actually tweeted out a photo of the single port Da Vinci robot that we have at Stanford now. And he was able to get 18 likes from this tweet. So it's actually, the minimally invasive procedures are pretty cool, and they're becoming much more widespread. Dr. Holsinger is going to be talking later in the afternoon. He taught me everything I know about robotic surgery. And he's an excellent surgeon. So, I think with additional training, more people are going to gain familiarity and sort of bring the technology into wider use. So I'm just going to give a brief overview of a few different kind of widely performed minimally invasive surgeries in head and neck. The first one I'll talk about is transoral robotic surgery. Then I'll talk to you guys about transoral laser microsurgery, which is an older technology. It's probably been around since the 80s, but gaining a little bit more popularity recently. And then a really new type of surgery is a transoral endoscopic thyroidectomy, where we're actually able to use instruments to get all the way down to the thyroid from the mouth. And then talk about some, even more emerging technologies that aren't really FDA approved or even in practice yet, but are undergoing clinical trials, and hopefully in the next 5 to 10 years will be in the operating room helping patients. So the, transoral robotic surgery started around 2008, 2009 at University of Pennsylvania. It uses this surgical robot. This is a 7-foot tall, 5-foot wide, 1,200-pound instrument that is actually incredibly delicate at performing procedures, even though it may not look like it. And the basic need for this technology for head and neck cancer patients is the oropharynx, and which is the tonsil in the back of the tongue. This is the fastest growing site for head and neck cancer right now. So the incidence of oropharynx cancer has actually overtaken all the other subsites for head and neck cancer, primarily driven by HPV infection. Back before the advent of transoral robotic surgery, patients with oropharynx cancer were almost exclusively treated with radiation. It would be very rare to offer surgery to a patient with tonsil cancer unless it was very small, back before the advent of robotics. But the problem was that patients that had already had radiation and had recurrence, they weren't able to get radiation again, and they would be, they would have to undergo really invasive procedures, including things like mandibular swing, where the jaw would have to be broken in order to access the back of the tongue. And so now with, and the reason for that is because we can't see back there to operate. And so now with robotic instruments, we're able to use flexible instruments and also flexible endoscopes to curve around the back of the tongue and see both the entire oropharynx, and then even do surgeries on the larynx. The way that this works is it's actually a completely different type of approach to surgery, where the surgeon isn't even sitting close to the patient. The surgeon sits, you can see on this console off to the side, right here. I don't know if you guys can see the mouse. Yeah, there we go. And there's an assistant that sits with the patient and the robot that kind of helps the surgeon with suctioning and other tasks during the surgery. This endoscope, you can see it has 2 cameras in it, which gives it binocular vision. And as the surgeon, we sit in this console and we're actually able to see in 3 dimensions how the robot navigates the back of the throat, and then use the instruments in a really fine way to perform the surgery. So it's basically doing like virtual surgery. You're not physically interacting with the patient, but you're relying on the robot to perform the tasks for you. And so again, it's a really different way of operating, but it's been really successful so far. We actually wrote a chapter for head and neck surgery textbook in England, Dr. Holsinger and I, based on minimally invasive surgery. And this is one of the figures from that chapter. It's a little bit cluttered, but it sort of gives you our setup at Stanford. We actually use what's called a single port robot now, where all the instruments come straight down this barrel and into the patient's mouth. You can see the robot is about half a foot away from the patient. And then, there's surgical instruments off to the side. Our console is actually way over here, where Dr. Holsinger or me or any other surgeon would sit to perform the surgery, and an assistant would sit at the bedside to, again, perform tasks to help us. And does it work? It actually works really, really well. This is like a surgery that has excellent outcomes. It's like any surgery, there's pain up front, but the long term, patients like 3 months out generally are doing really well, back to their normal diet. Very low rates of like G-tubes, on the order of like 1% patients needing a G-tube after the surgery. And then in addition, the surgery is becoming the basis for something called de-escalation, where even patients that have a lot of lymph nodes or have bigger tumors, if we're able to remove the cancer, they may actually get the radiation dose reduced, which has important uh, you aspects for them, like down the line, as far as decreased toxicity. As any of you guys have gone through radiation, know that those last like 3 weeks of radiation are usually the worst. And so if you can avoid those, potentially avoid needing a G2 placed or something like that. And then the robot's also been used for surgery in the larynx, the hypopharynx, and it's kind of sort of, reaches, or the uses are being developed even for the skull base and other parts of the head and neck. So that's TORS. The other kind of similar to TORS, but a little bit older technology is laser microsurgery. And this is primarily used for larynx and vocal fold cancers. And, these tumors, even when they're small, they can affect a patient's ability to speak, swallow, breathe. You can see, some photos of tumors here. Now we have really sophisticated imaging technologies where we can use filters to sort of see tumors spreading, that we can't even see with a microscope. So these tumors can be treated by radiation, but again, radiation can only be given once. And in patients that have recurrence after radiation, traditionally the laryngectomy has been sort of the surgery of choice. And so this is a much less invasive procedure than a laryngectomy that can cure cancers and buy patients time. The principle is using laser energy, which has a really predictable penetration of tissue. It cauterizes. It's just very effective at removing tumors. And we use all sorts of instruments, but I mean the workhorses are the laryngoscope, which we use to kind of give us a line of sight to the tumor. There's actually a laser manipulator that we attach to the microscope, and we're actually able to use micro manipulations to deliver laser energy to the vocal folds. The vocal cords, like these structures that I showed you, they're less than an inch long. So, this is like a microscopic surgery with like very fine movement. And the laser is also like the perfect instrument for that, because we're able to make the laser a little dot, like less than a millimeter, in size if we need to. So we can really control where the energy is going. This is kind of how things look when we're doing the surgery. It's like a little bit different than robotic surgery. We're still physically interacting with the patient. There's a surgeon standing at the microscope. You can see in this picture, his hand is on the micro manipulator, and he's just using very careful movements to direct the laser to resect the tumor. I do microvascular surgery, and I think these kind of laser microsurgeries are one of the few times I actually have to hold my breath in order to steady my hand. It's like a very fine movement. Does it work? It actually works really well. You can see, in this picture up here, there's a patient that had a pretty large resection of a vocal fold cancer, basically their entire vocal cord. And then a few weeks later, this area is healed remarkably well. You can see in this case down here, a patient has, probably a smaller resection of a more superficial tumor. And then a few weeks later, it looks like nothing ever really happened there. The vocal folds have a really good capacity for healing. And then the cancer cure rates are very high as well. Like, for small tumors, we're talking about like 95% cure rates that are better than even radiation. And for larger tumors, it can be a little bit lower, like probably closer to 70-80%. But still, especially in cases where we're avoiding a laryngectomy, that trade-off is huge for patients. Sort of the newest technology I want to talk to you guys about today is a transoral endoscopic thyroid surgery. This is actually one I don't do. We have a couple surgeons, I guess just one now, Dr. Orloff, that does this here at Stanford. And you guys may not know, but thyroidectomy, it's one of the most commonly performed procedures in the United States. And the rate of thyroidectomy has actually increased a lot in the last 30 years. So we're finding a lot more thyroid cancers. there's kind of controversy as to whether we're finding more thyroid cancers because we're just looking more, or if there's like a true rise in the rate of thyroid cancer. So part of that is, we may be doing some thyroidectomies in patients that, may just be observed and do okay over time. Thyroidectomy, it's overall like a really safe procedure. Like I said, there's 100,000 of them performed in the US, so surgeons are usually really proficient in performing them. But the one downside is that with the thyroidectomy, there's a visible scar on the neck. Some patients have concerns about like their health information. They're sort of walking around, with a scar, which tells people like, hey, you've had some kind of surgery. People ask questions, and so there's some need for doing like a scarless surgery. I would say that this is like not for everyone. I think most folks are just fine with having a traditional thyroidectomy, but for patients that have sensitivity to scars, it is something in the tool bag to use and offer for them. This one's a little bit complicated. It's not technically scarless. We're exchanging the scar on the neck for actually a scar on the bottom of the lip, between the lip and the jaw. And all of the tissues of the neck, they're connected to each other. So we can actually tunnel from the bottom of the lip, kind of under the jaw, through the skin, and using like laparoscopic instruments where we're able to put air into the neck, inflate this area over the thyroid gland, and then perform the surgery using laparoscopic instruments. And again, it's just sort of like crazy that this is even possible, but it actually works really well. The one downside is there's a couple of nerves here that provide sensation to the chin, and those nerves do get injured, not that frequently, but that's sort of the one risk where sometimes patients will have chin numbness after this procedure. And I would say, again, this is in the last maybe 5 years where this has really taken off, and the results have been really good. Patients, especially in countries in Southeast Asia where this is performed much more frequently because of kind of cultural biases against neck scars there, their reported cosmetic outcomes are really good. All of the traditional risks with thyroid surgery are about the same. The risks of having a nerve injury that can lead to breathy voice is about the same with this newer surgery as compared to traditional thyroidectomy. And then the biggest limitation is still time. This is a much more time-consuming way to perform a thyroid surgery than just doing a standard open surgery. And someone, this is like a group from Thailand that does hundreds of these a year. They can do this transoral in about 100 minutes compared to an open in 80 minutes. I would say, just hearing from people that do this procedure, this is probably like double that for surgeons that are just starting out doing it. They may be able to do it safely, but it really takes a lot of repetition to get down to this 100-minute threshold. So I think in most places you're still looking at like a surgery that's 2 to 3 times as long as a traditional open surgery. So this one I think has a little bit more like risks and benefits and discussion associated with it. And then, really thinking about the future, I was, thinking about a few things that I think are on the horizon. One of them is remote surgery. So as I mentioned before, with the transoral robotic surgery, we're sitting away from the patient performing a surgery, a few feet away in a virtual environment. There's nothing that says we can't do that, with someone across the country or across the world. There are some issues with time delay when we get really far away, when we're talking about doing surgery from Stanford on a patient in Africa, for instance, but for the most part, those can be worked out. Crazy enough, like there was actually a gallbladder surgery performed in New York on a patient in France back in 2001 over a 10 megabyte per second internet connection. So you can think, we're like 1,000 times faster than that now with much more sophisticated robotics. So there's nothing that says we can't do it. I think the biggest limitation now is just that this Da Vinci surgical robot costs over $1 million. And so really they only exist in places where you have surgeons that know how to use them. And so you could think about technology and just the rate at which the cost decreases. At some point, it's probably going to become feasible to deploy these surgical robots to places that are much more remote, where they may have a surgeon that's not necessarily trained in robotic surgery that can assist at the bedside while someone, from Stanford or from another institution is actually doing a virtual surgery on a patient. And I think the, biggest applications for this are probably the military. DARPA is investing money in remote surgery, the Department of Defense Research Group, and then, potentially mission work and others. This one's really cool. Augmented surgery, thinking about like something like an Oculus or like a Google Glass, but like specifically made for surgeons. Especially with artificial intelligence now, it's possible that something could be integrated into glasses for surgeons, and we're able to see anatomy, we're able to see fluorescence dye or some kind of radioactive tracer that, you can't be seen with the naked eye, and that can help the surgeon to operate better and potentially more quickly and potentially in like a more minimally invasive way. The biggest application now, I think, is actually mostly for training. So again, helping medical students, residents train in a virtual environment where they can make mistakes. There's not really any, it's not high stakes like it is in the operating room, and help them go through the case in preparation for when they become surgeons and can actually do this on their own. I think that's currently the biggest use of the technology, but in the next 5 years or so, it may advance to a point where like attending surgeons are wearing them and actually interacting with the tissue and doing surgery with them. And then kind of to piggyback off that, another aspect, and there's hundreds of these clinical trials now, are real-time imaging modalities. We had a surgeon that some of you may know, Dr. Rosenthal, who was a head and neck surgeon here for many years and left to become chair of Vanderbilt's otolaryngology department. And he was very invested in imaging of tumors so that a surgeon can actually see where the tumor goes based on a fluorescence marker. Because now we kind of rely on the way it looks, feels, but there's nothing like definitive about, this is tumor, this is not tumor when we're operating. But you can invent, tags that are, fluorescently glowing that a surgeon can see and actually, see nerves, see tumors, see all sorts of different structures. And again, potentially we can sort of have like a multiple of these like interacting together so that like the environment in which we're operating is like much more rich with information, and we can limit how much of the normal surrounding tissue we take out, and again have like a more focused, and maybe not minimally invasive, but definitely like a less destructive surgery for removing cancer. So, hopefully I gave you guys an overview of ways that we're working to make patients' lives a little bit easier. It's really early on. We're kind of at the dawn of all these technologies, and I think that they're going to evolve even more in the next 5 to 10 years. We are working with engineers. The folks at Intuitive, they come and talk to Dr. Holsinger, and they're involved with him in clinical trials and making the robot better. So it's kind of a partnership between the surgeons, engineers, between oncologists as far as figuring out what are the best types of surgery. And then, unfortunately, we still are, actually most of the surgeries are still pretty much the same as they've been for 40, 50 years. But I think that we're sort of moving away from that now, and hopefully in the next, like I said, 5, 10 years, we'll be even, it'll just be kind of like the difference between like the, technology information age and like the 1950s as far as like our ability to operate and to help patients. Yeah. Thank you guys.